Good afternoon and welcome to today's joint CHEPA HEI seminar entitled Tried and True or New and Improved Using Clinical Guidelines to Balance Innovation and Expertise. It's presented by Valentyn Litvin. And so Valentyn is a PhD candidate in economics at Northwestern University, where they focus on health economics theory. So in the seminar, he'll draw from a research paper theoretically examining how clinical guidelines should balance treatment effectiveness and provider expertise. So I think, Valentyn, you can take it away.
Great. Thanks, Aaron. Yeah, so let me just share my screen and then we can get going. And also feel free to ask questions throughout the presentation. I'm comfortable with that. Okay. Here we go. All right. Can everybody see you okay? Just confirm. Yeah. Okay. Great. So today I'm going to talk about my paper, Tried and True or New and Improved, using guidelines to balance innovation and expertise. And so the motivation for this paper is clinical guidelines themselves, right? So within clinical guidelines, an evidence-based view is widespread. So briefly and broadly, what does this mean? This means that guideline developers should take quality evidence, such as those from randomized clinical trials, for example, identify the best treatment for some group of patients, and then recommend that treatment to clinicians. Now, the information in this quality evidence, right, comes from trials that are typically about treatments, right? They give treatment effects and are typically not about the clinicians that the guideline ultimately gives recommendations to. And so this kind of blind spot has only a limited response in research and policy, in that the pipeline, right, of information going to guideline developers and then going back to clinicians doesn't include a lot of rigorous information about the clinicians themselves. So some examples away from this that are limited, right, are, for example, the United States Center for Medicaid and Medicare Services, CMS, they give transplant funding to centers, right, conditional on a minimum volume requirement for clinical experience. So if a center, for example, wants to conduct kidney transplants, they need to be doing at least 3 a year in order to demonstrate that they have clinical experience, whereas typically clinical guidelines don't condition on clinician characteristics, whereas they do on, for example, patient characteristics. So this leads to my research question, right? How should guidelines account for clinician skill? Now, this paper is going to be theoretical. It's a theory of guideline policies as tools to manage skill. What do I mean by skill? I mean any technique or knowledge that's acquired via practice. So this could be either physical techniques, such as using a scalpel to perform a certain procedure, right? Or it could be knowledge that isn't or just can't reasonably be communicated in guidelines, such as how to determine somebody's biological age, or how to properly dose a drug given a wide array of patient characteristics. And what I mean by guideline policy, so in the context of this paper, I'm going to be it's going to function in the model as a subsidy for recommended treatment. So I'm kind of combining guidelines and non-clinical interventions, NCIs, that are based off guidelines that try to, for example, encourage a clinician adherence to a guideline recommendation. So in my model, there are going to be 3 types of actors. There's going to be the social planner, or the guideline developer, who chooses a guideline policy for a group of clinicians who choose treatments for a group of patients. Right? And the main model ingredients that are going to interact with these 3 actors to eventually get my results is, one, that there's heterogeneous patients, that clinicians can't self-select into patients that prefer one treatment over another. They have to treat a group of patients which some may prefer one treatment over another, respond better to one or another. And so this limits myself to settings where clinicians have to treat a wide population. So, for example, for maybe very rare diseases, this isn't the case, but I'm going to give an illustrative example where it should reasonably apply. The second ingredient is recent learning by doing. So there's empirical evidence of this, especially in fields such as surgery, where it's not only the experience that a clinician has that influences the outcome of the treatment for the patient, but also the recent experience they have. So if, even if somebody's been doing a procedure for a long time, there's evidence that once they take a break or they start doing fewer, their skill kind of drops off. So in my model, skill is going to require constant practice. And the third is a time horizon wedge. So what I mean by this briefly is that the clinician and the social planner, the guideline developer, are operating at different timelines when they make their decision, and the guideline planners are more long-term focused and more considering long-term or the outcomes of patients in the long term, right, in the future, compared to patients today. So what are my findings? So given those model ingredients, I find that learning by doing matters for guidelines, but more specifically, that optimal guideline policy, it doesn't only look at treatment effectiveness. So this is, evidence-based medicine, I think, is wonderful, but it does focus on, trying to identify treatment effectiveness. But I think it misses the also important ingredients I highlight here, which is initial clinician skill in different treatments, and also the ease of mastering treatments. So guideline policy should not only try and identify the most effective treatment, but also one that has some, existing human capital in performing it, and also is easy to learn. So what's my first headline finding? Is that it may be better to recommend a tried and true treatment that is worse, right? So even if a treatment has worse, let's say, RCT results, it may be better to actually recommend and subsidize and encourage. And the second headline finding is that optimal treatment may change after shocks, such as rapidly changing widespread patterns of treatment, right? So the surprise here is that even if nothing changes about the patient's population or the treatment characteristics themselves, a change in provider skill can change the optimal recommendation to a totally different treatment. So this headline finding says that guideline development is more complicated than we may have thought of it before, where you need to look at the kind of current characteristics of clinicians, not only just some kind of a meta-analysis of over the past. So what's the contribution here? So I broadly see the contribution in two strands. The first is the literature on clinician behavior and learning by doing, and specifically, the health economics literature on this. And what I contribute is showing how the evolution of behaviors, clinician behavior, responds to guideline policy. Right, so showing in a kind of dynamic system, right, how clinicians respond to guideline policy by changing the treatment. And in terms of guideline development theory, here there's a very, very sparse economics literature. There's only a handful of published papers at all. But this intersects with, of course, the wider, far more developed literature in terms of guideline development in other fields, such as talk about grade, for example, right? And what I show is in all these fields, as far as I know, I show I'm the first to show the effect of learning by doing on what should be optimal guideline policy, right? And a moment about the scope here. So in my paper, guidelines manage skill; they don't manage knowledge. What does this mean? So I abstract away from this question of how guidelines actually influence clinician beliefs, right? So I think this is a very important question, but to model it mathematically in a dynamic system, it's hard. I'm working on it now, but that's not the scope of this project. So in this paper, I kind of take an I abstract away, and I look at a situation of perfect knowledge. That is, all clinicians and the guideline developer know how every patient responds, to every treatment. And this, I think, serves as a kind of baseline that shows that even if we take away this uncertainty about how treatments affect patients, there's still a role for guidelines in terms of differing incentives, right, different preferences between clinicians and guideline developers, right, for guideline policy to try and influence clinician behavior, right? So even in a perfect knowledge world, there's still a role for guidelines as skill management tools. So I'm going to briefly discuss an illustrative case, go through my model. If there's time, go through an extension, and then discuss and conclude. So let's talk about the illustrative case of breech birth. So breech birth is when a fetus is facing feet first or buttocks first, and there are two treatments, right? One is vaginal breech delivery, which I'll call VBD, or cesarean delivery, which I'll call CD. So in any case, breech birth is somewhat risky, right? VBD and CD, they're both procedures that require practice with implements, such as scalpels or vacuum, or vacuum assisted birth. Both of these treatments are complicated and require practice. And my model fits this breech setting, right? Because there are heterogeneous patient needs and preferences, right? Not every patient is clinically is going to have better clinical outcomes, from simply one or the other. There is learning by doing, and it demonstrated, learning by doing in both of these treatments. And there are non-clinical intervention, NCI policies that incentivize the use of cesarean deliveries based on guideline recommendations, so based on this idea of overuse of cesarean deliveries. So there are subsidies that, kind of like in my model, right, actually do encourage the use of one treatment over another. And so let's talk about the guideline policy and a series of events that shaped it over the past 25 years. So in the year 2000, a major trial called the Term Breech trial came out that strongly favored cesarean delivery for breech. Now this helped. Now the resulting clinical practice guidelines helped cause a moratorium on breech deliveries. And for example, in the Netherlands, cesarean delivery for these patients was about 50-50 in 1998. And then after this trial, within 4 short years, there's a drastic change. Where now 80% of patients were receiving cesarean deliveries because the consensus was, breech is dangerous. Sorry, VBD, vaginal breech delivery is dangerous. But the follow-up evidence cast doubt on these trial results. And then guidelines partially reconciled vaginal breech delivery, but there are still non-clinical interventions, right? There's still subsidies and fee equalization schemes and administrative, intentional administrative costs imposed on cesarean delivery, right? But there's another element, right, to this that has been, not formally analyzed, I think before this paper, which is alarm about skills being lost. Right? For example, medical authors, right, in polemic articles say that planned VBD is a rare event. A common limiting factor is the lack of a provider skilled and willing to offer VBD, and we are left with an entire generation of obstetricians lacking sufficient training to provide VBD. So it's not only a question of what treatment is most effective, right? In this case, clearly there is some lasting effect from the change in treatment practice, right, that leads to a change in skill. So how does this skill actually accumulate or disperse? So this is what is called in at least economics, right, recent learning by doing. And there is evidence that this exists in different surgical procedures, including cesarean delivery. So there's evidence that surgical skill depreciates quickly. Yeah, thank you, Jonathan. Yeah, and for cesarean delivery, Ficini, a health economist, finds that learning from recent experience effects may be substantive, and only very recent experience, that is 4 weeks, matters. So even for skilled clinicians performing cesarean deliveries over and over again, the number of procedures they perform over the past 4 weeks is indicative of patient morbidity measures, right? And so this shows that even with something that somebody does all the time, right, practicing it less in the recent term means their skills get rusty, which is a little bit surprising, but is useful to know. And multiple papers find similar effects for cardiac surgeries, angioplasties, and the like. And so, given this illustrative case, to keep at the back of your mind, right, of these changes in guideline policies and losing skills, and the fact that clinicians, right, have recent learning by doing, how can we model this mathematically and get some kind of insights? So the model I have is going to be a multi-period model. So it's going to be period 1, period 2, period 3, so forth, discrete periods. And these periods can represent, I'm kind of agnostic about what they necessarily represent, but reasonably they can represent months, they can represent years, right? And there are two treatments, treatment A and treatment B. So you can think about VBD and CD in this case. There's a population of patients. And here I say that the population doesn't change over time. So there's a new identical cohort, every period that shows up to be treated. And each patient has an individual treatment response, right? So they each individually have some kind of response, idiosyncratic response to treatment A and treatment B. And that this is common knowledge. That is, all the clinicians and the social planner, they all know what these responses are. And so there's no question about what treatment is better. Right. And I started with an identical population of clinicians. So in an extension, I remove this to allow clinicians of different skill, right? But I start in the baseline with identical population of clinicians. They see, identical slices of the patient population, and each patient is treated once. So it's not like a health economics paper by Perry and McLeod. There's no within patient experimentation, right? You're just treated once, and then you leave. And this is key for the model. Clinicians have treatment-specific skills, right? So the skills, for example, in VBD, or at least some portion, right, won't transfer over to cesarean and vice versa. And these skills accumulate via recent LBD. So because I have a discrete period model, what I say is that the skills only depend on the past treatment use, right? So you can think about this, not maybe on the scale of 4 weeks, right, but on a scale of several months or even several years, right? If you haven't been using a particular treatment, you lose as a clinician that your skill in that treatment, right? To some extent, right? And then the third actor here is the social planner. And so what do? At the start of each period, the social planner chooses an NCI policy Z. So Z is a subsidy, right, to the clinician for each use of A. So you can think of a higher Z that's positive as being a bigger subsidy to the clinician, a payout for, and this doesn't have to be a financial payout, just within the model, it's a numerical value representing how happy the clinician is additionally to do it. Okay, so what's the friction in the model, right? Because there's no friction, which is what we usually think about clinical guidelines, right? There's no friction in clinicians and social planners in terms of knowledge. There's no disagreement about, which treatment is better, right, for the patient, for a particular patient, right? Now, there could be kind of a standard economic treatment of differing preferences over treatments in other dimensions, right? So, for example, fee or cost preferences, that are common, such as clinicians like getting paid a lot. Maybe society doesn't necessarily want them to get paid, particularly want them to have high salaries, and so there's kind of a disagreement there. And the model can accommodate this friction. It's simply a subsidy in one direction or another, right, or a cost imposed in one direction or another to internalize society's preferences, right? So have each clinician kind of internalize the society's preferences on what treatment should be used, right, kind of regardless of the underlying fees, right? But this kind of misses the main point, right? This is somewhat of a simple, almost static, right, solution and a static problem that misses the complexity of this changing skill, like we saw with vaginal breech delivery, right? So the main friction that I introduced is a time horizon wedge. So clinicians, relative to the social planner, care more about short-term outcomes. And I think this is a reasonable assumption, right? Because when guideline developers meet, right, they do so every couple of years, maybe every 5 years, 10 years, right? Depending on the guideline, and especially if they're taking in cost, effectiveness considerations. If they're, for example, working, for NICE in the UK, there the time horizons, right, can be substantial. So the social planner is thinking more about the long-term, right, implications of their decision versus perhaps a clinician who is faced with a patient right in front of them and thinking about, what is best for that patient, right? So I don't need, what I don't need is, in this wedge that clinicians are totally focused on the patient in front of them, and, social planners are totally, kind of looking to infinity. All I need is a wedge that is there's some relative difference between the two agents where the clinicians are more short-term focused. Now, for tractability, right, to be able to explain the results and understand them more deeply, I started the baseline with the strongest version of clinician myopia. This is the strongest kind of most short-term view for clinicians, which I call a no sacrifice constraint. So clinicians only care about one period. That is, they are unwilling to sacrifice the welfare of their current patients in order to learn a skill they would like for future patients, right? Because in order to learn a skill you don't know, you kind of have to mess up a little bit at first, right? You don't have that additional skill-specific, treatment-specific skill. And so in order to gain that, you have to mess up some patient outcome, right? And so I say that clinicians don't do that, right? That they do what's best for the patient in front of them, which is, it's the strongest version of this time horizon wedge. But I have an extension that shows that if clinicians are allowed to strategically, right, kind of plan their future skill trajectory, they say, okay, I want to learn this in the future, the results are qualitatively the same. Right? And so I stick with this myopia, right, where clinicians are totally focused on the patient in front of them, but not out of necessity, like out of tractability, right, in case there are any concerns about this assumption being too strong. Okay. So just kind of more, a more nitty detail. I assume individual responses are zero mean, right? Just kind of to make the distribution nice. And the patient payoff, right, is then going to be a sum of the mean treatment outcome, mu t, right? So for each treatment t, there's a mean treatment outcome, an individual treatment response to treatment t, and the clinician scale in period n of treatment t. So the full patient payoff is going to be the sum of these three things. So you can think of mu as kind of the clinical trial outcome, right? This is the mean effect of this treatment that's publicized. The epsilon is how an individual patient differs from this kind of clinical trial outcome. And the eta, clinician skill, right, is the clinician treatment-specific skill that they have acquired from practice. And what I say is that the clinician essentially cares about two things, right? They care about the clinician, the patient outcome in front of them, and they also care about the subsidy. So they do respond to pressure, right, in the short term. So if there's administrative pressure or financial pressure or other kind of pressure, they will bend to it, right? As is the case in reality, right? And so that's what the clinician is trying to maximize with their decision is this outcome of the patient outcome plus the subsidy. So the clinician decision rule, right, and this is the result. So in terms of notation, if there's no script, because there's two treatments, it's A relative to B. So for example, epsilon is the patient-specific relative outcome of A to B. And so the result I find, right, this is a simple one to start, is a simple threshold rule that says that the clinician, optimally has chooses a threshold T in each period n, right? So Tn, such that if the patient's affinity towards A, right, if their individual treatment outcome, relative of A relatively to B, is high enough, then they get A. And if it's below this threshold, they get B, right? So the patients who prefer A above some threshold get A, who prefer B below some threshold get B. And this threshold depends on the relative, essentially, trial outcome, right? The relative mean treatment effects, the relative clinician skill. And remember, this is an identical, we're starting with an identical population of clinicians. It's just one mega clinician with the same skill. And also the subsidy, right? And so you can see that the subsidy, as you move Z up and down, it's going to shift this threshold. So if you move Z up, for example, if you give a bigger subsidy to A, the threshold is going to move down, and so more patients are now receiving A, right? So the policy is going to shift the treatment for the marginal patient at that threshold, right? So if you increase Z, it's going to move them from B to A. And so this leads, yes.
Yeah, I have a question. So I'm thinking about Chang and Scale Yu, where they kind of find that providers might kind of overcompensate by maybe doing more if they know that they have lower skill, in this case, in their case, diagnostic skills.
Yeah.
It doesn't perfectly translate into yours because there's no diagnostic skill, right? You kind of know what the heterogeneous treatment effect is. But is there any aspect of that where you might want to do more if you're uncertain about your skill?
Yeah, so I have thought about a different axis, kind of a margin for effort, for example, right? So here, I think actually the diagnostic skill does translate into this setting, a skill. But yeah, so I have thought about this kind of axis of effort, right? But that's I'm still working on that. That's kind of future work. My kind of preliminary thoughts on that, right, are that I think it would dampen, right, that depending on the amount of effort, right, clinicians could put in, right, that I think it would dampen the results. But I think especially right, especially for very difficult procedures where it might not be the same as a radiologist spending more time studying a particular image. Like if it's a C-section, it might be more difficult to exert more effort in the moment. So I think especially for cases like surgical procedures, it may be less of a factor, right, than for scans, for example. Is there any follow-up on that question? Or does that? Oh. Yeah. Okay. So the policy shifts the marginal treatment, or the treatment for the kind of marginal patient, right? And so the social planner, right, their decision problem here is to choose a series, right, of policies, and because here there's perfect knowledge, they can perfectly choose this. There's no distribution of possibilities here. They're just going to choose the optimal path of subsidies, right, to maximize patient welfare. And this is going to be a discounted sum of patient welfare, right? And I allow for the subsidies to go to infinity or negative infinity, so guidelines can be binding, right? So of course, this isn't realistic for all guideline developers, or for most, but excuse me, I do this to kind of see, especially for the developers that can bind a decision more or less, right? When would they like to, right? And so a quick model specification, right? I have a uniform distribution for this patient-specific characteristics. Looking at also logistic distribution, it's broadly similar. I don't think I think a well-behaved distribution in some sense is probably going to have similar results to what I find here. I have linear learning by doing, and I've also experimented with having a kind of asymmetric. Very kind of asymmetric functions, functional forms for learning by doing another thing. But once again, this isn't really something that yielded different results. So I'm just kind of sticking with the basics here, right? So linear learning by doing, where the skill is a linear function of the past use, right? So if you use if you've given a lot of A to patients in the past period, your skill in A is going to be better. Now, in terms of the parameters I'm going to use to describe this model, right? Gamma T is going to be a parameter of the learning by doing effect for T. So higher gamma T means that, kind of for the same amount of patients treated, for example, with A, right? The learning by doing effect, right? The skill in A in the next period is going to be higher. And I'm going to take a parameter that I call phi, right? And phi is going to be the relative advantage in learning A versus learning B. So a positive phi means A is easier to learn in B, right? That this gamma, right, is these gamma t's are asymmetric in the sense that it's easier to learn A versus B. And I'm going to define just a subscript less gamma as the average learning by doing effect. So as you can see here, the gamma A, right, is going to be this average plus the relative effect of A. And then gamma B is going to be this average minus this kind of relative effect towards A, right? So just to clearly remember, right, gamma is the average learning by doing effect. Like how important is practice, right, for this setting, for both these treatments? And then phi is going to be the relative effect of practice on future patient outcomes of A versus B. Okay, that's gamma and phi. So I take two approaches in this model. Briefly, I take an analytical approach, looking at 2 periods, looking at infinite periods with a permanent policy, so one policy throughout the whole setting, and this shows the core mechanism of the model. And then for more robust results, right, I take a computational model where I use value function iteration for infinite periods with a flexible, dynamic path of policies, and this shows the evolution of skill. This shows the richer mechanism dynamics. So let's look at the results. So the core mechanism, right? Looking at first order conditions, it shows that clinician myopia, right, caring about the patient in front of them and not about the future populations, right, means that clinicians are not strategically, and for themselves or kind of for their fields, for the people they're going to teach in the future, right? Like we saw with VBD, right? They're not strategically planning the skills off into the long future. And so the social planner who is doing that, who would like to manage the skills in the long-term future, is going to use the policy today to improve the skills that they would like tomorrow. But this comes at a cost. Because clinicians, without a subsidy, kind of are perfect agents for the patient in front of them, right? They care about the patient in front of them, that outcome and nothing else, right? Without any kind of subsidy, any subsidy moves them away from that baseline. And so it's going to cause a harmful distortion that causes them to relatively harm patients, right? Or give them treatments that are worse for them. And so the marginal switching patient, right, is hurt by this level of subsidy. So as you push the subsidy higher and higher, clinicians are pressured, right, to give patients who have a worse and worse relative, right, trade-off their less preferred treatment. And so the idea here is that the policy, the subsidy, balances between beneficial movement towards future skill and harmful current treatment distortion. Right. So it's kind of the beneficial. So the benefits are centralized move towards a skill profile that you would like, but it harms in terms of everybody. It's kind of following, the same step, even though patients prefer different treatments. So the static results here, I give an analytical solution, but the short of it is that optimal policy is a weighted sum of the relative trial outcomes, the relative starting skill of clinicians in each treatment, and the relative learning by doing strength, right? How easy it is to learn each treatment. So suppose that A is more effective in trial, right? Then mu is positive. Well, there could be an optimal policy that recommends B, right? There could be a guideline developed that says, I know this is better in a trial, but you should not use it. If there's more existing clinician skill in B, right? If it's tried and true, don't lose that skill, it helps patients. And if clinicians gain more skill in B and A, if B is easier to learn, even if a newfangled procedure or drug comes out, but it's difficult to learn how to dose it, it's difficult to benefit patient outcomes, right? With prior patient experience, maybe it's not worth it. So the main idea is that if it's tried and true, you should recommend less effective treatments. Right? And the second idea is that if it's easier to master, you should recommend less effective treatments. But this is a departure from the kind of standard idea of, accumulating trial evidence, seeing which treatment is more effective, and recommending the more effective. So in terms of dynamic results, right, I use value function iteration, like I mentioned before. And just briefly, I have two steps. First, I find an optimal policy. So this is going to be the proportion of patients that receive A, this data, the proportion of patients that receive A in the next period, as a function of the proportion of patients who receive A in this period. Right? And so you can see that there's a function that maps from the use of A to the use of A. And I'm going to find a trajectory of these treatment patterns, right? These proportions of patients who receive A instead of B, given some starting condition, theta 0. And then I'm going to compare the trajectories to long-term steady states, right? So I'm going to compare them to the optimal steady state that the social planner would like, right? As the model settles down, for the long term, and the laissez-faire one. So this is a situation where I say there is no social planner, there is no guideline policy. Clinicians are simply kind of evolving on their own, being myopic in each period, right? Without thinking about the future, right? How does that situation evolve? And I'm going to give 3 examples. Oops. With different gamma, the average learning by doing effect, and different mu, the relative effectiveness of A versus B, in a trial. And these 3 examples are going to give qualitatively different scenarios that I think are interesting to examine within each one, right? And for each example, to show how phi works, and it's pretty, the effect of phi is pretty uniform. So for each example, I'm going to start with a baseline where phi is 0. That is, A and B are equally easy to learn, right? That gamma A and gamma B are both just gamma. And then one where phi is less than 0, that is, B is easier to learn than A. So there is some kind of asymmetry in how easy it is to master, right? To gain skill from patient use. So a quick overview is that, in the static policy, we saw a balancing not just of treatment effectiveness, right, but of also ETA, the clinician skill, and phi, the ease of learning. And the dynamic solution also balances these ingredients, right? But it depends on the setting. So it depends on which example we're in, out of 1, 2, or 3. And it can either depend more on the kind of time invariant parameters, that is the trial results and the ease of learning, or it could depend more on the starting state, right? That is, what is the starting human capital when the guideline developer makes a decision? And also, it can have an interior or a boundary solution. That is, an interior one is where clinicians optimally mix, that is, some patients get A, some patients get B, or a boundary one where every clinician moves to a consensus, right, of everybody is going to use A or everybody's going to use B. And a characterization, right, of this policy is the following, right? So in example 1, when learning by doing is low, so you can think of a case, that perhaps prescribing a drug that's easy to dose, that doesn't have a lot of polypharmacy issues, right? Maybe the learning by doing availability there is pretty low. Patient outcomes aren't going to be changed by experience very much, right? And and mu is high, so there's a large difference, right, between the trial results for A and B, on average. Then here the policy driver, right, is going to be these time invariant parameters, and there's going to be mixing. In example 2, where learning by doing is high, so something like surgery, right? And also there's a big difference. We're going to see the same time invariant parameters matter, but now everybody moves to one treatment. And then in the third example, where learning by doing is high, but the drugs in their trial results are relatively similar, right? Or the treatments rather. So like the procedures, surgical procedures, are somewhat similar, as is the case with VBD and CD, for example. Then the policy driver is not going to be a time invariant parameter. It's going to be where you're at right now. Which, if you remember the second headline, is going to drive that problem of guideline policy depending on current clinician characteristics, complicating the policy problem. So let's look at the first example. So because this is where learning by doing is low and the relative, mean treatment effect is high. So because gamma is low, the returns to specialization are low. And so clinicians prefer to use some A and some B, right? Because remember, we have a heterogeneous patient population where some prefer A, some prefer B. Right. And so clinician skill can't make up for that. And so the social planner's role here is to encourage an optimal mix, right? Is to nudge clinicians towards getting a mix that is optimal. And the starting position matters only for the dynamics to get to that optimal mix, not for the actual goal itself. And the static intuition applies here, where you choose a treatment to recommend based on a weighted sum of the relative treatment effect and how easy it is to learn. So, for example, here's a graph of the optimal policy. In example 1, when learning by doing learning by doing is symmetric, right? There's no, it's not easier to learn one treatment or another, and phi is 0. So on the x-axis, we see theta n, that is the proportion of patients who receive A this period, or have received it in the past period. And theta n plus 1, right, on the y-axis is, if we're taking this convention of theta n is the past period, theta n plus 1 is this period, then this is what the social planner is going to choose, right? The blue line is that policy. So you can see, for example, if no patients were receiving A last period, then the optimal policy would be to choose a policy Z, right? So to pressure clinicians enough such that about 44% of patients this period are going to receive A. And the orange line at around 0.6, 60%, is going to be the steady state, right? So if 60% of patients receive A, then the optimal policy is to give about 60% of patients A. And so we can see that reflected here in these trajectories, right? So you can see on the left plot, for example, whether you start at 0.8, so 80% of patients receiving A, or 20% of patients receiving A, the optimal policy converges to the steady state, where about 60% of patients receive A, right? So some mix, 60-40 split for A versus B. And on the left-hand side, on the right plot, we see that this convergence, right, in a setting where there is no social planner, where there is no policy, still happens. Because clinicians, what's going to happen is clinicians, right, their skills are going to evolve, right? So, for example, those that are treating, 20%, are going to have, they're going to have a high skill in B and a low skill in A, but A, has a better trial outcome. It's better on average. They're going to slowly converge, right, to a point above 0.5, right, but still below the optimal, right, the optimal mix. And so the goal of the social planner here, as we see on the left-hand side, is to get clinicians to converge to the optimal mix. But again, remember, not instantly, right? It's not that everybody packs their bags and we're all, moving to this way of treating patients. It's a gradual process because distortions to clinicians' human capital, right, is harmful to patients. That's getting everybody to move all of a sudden means getting everybody to practice very differently today, which harms patients because it's really not suited to the current level of skill that clinicians have. Right? So this is a gradual process. And then if we make B easier to learn, what we see is that, well, first of all, the number of patients who receive B increases, right? But second of all, so if you notice, for example, here, on the right plot, right, the laissez-faire steady state is lower than the optimal one, right? That is, the social planner is constantly pressuring clinicians to choose A. Here, they're constantly pressuring clinicians to choose B. Why did that difference happen? It's because B is now easier to learn. So the lesson here is that although the qualitative structure of the problem remains the same, if you change an ingredient such as how easy, or they change the value, right, of how easy it is to learn B versus A, the actual recommendation can change, right? So the actual recommendation from, hey, we're subsidizing A to, hey, we're subsidizing B can change, right? So this is why, to translate this, right, to a concrete example, I mean, sort of a concrete, tool for, let's say, guiding guideline developers, right, there needs to be a quantitative assessment, right? So this is a call for action kind of to get more good data on how easy it is to learn treatment, right? Because this is not something that is well researched yet, at least not for most procedures and drugs. So in the second example, where learning by doing is high, and the relative treatment effect is high, we have that gamma is high, right? Learning by doing is high, so the returns to specialization are high. That it's good to specialize, right? And because A is relatively, much better than B, it's good to specialize in A. However, because learning by doing is high, this can cause a drift to a situation where everybody gets B. And the kind of logic very quickly is that if you're a clinician who's already specializing in B, right, you already have a lot of skill in it, and you have very little skill in A, you're not practicing it. Then even though A is a lot better, in trials, you're going to hurt your patients if you give them A because you don't have that skill. Because the effect of your practice really matters on patient outcomes, right? And you can imagine that with surgery, right? Even if one surgery is better than another, if you haven't practiced it, that could be really dangerous to patients to some respect, right? And so there may be a convergence to kind of the wrong, right, equilibrium for a clinician group where they start off specialized in B and they stay specialized in B. And so the role of the social planner is to either accelerate the move to a full specialization in A, or to redirect those B clinicians, right, who are kind of obstinate, but in this model, correctly so, right, because they would be hurting their patients otherwise, right, but to redirect them into a better situation for the long term. And here we're also depending on this kind of time invariant parameters, right, and not the starting position. So the optimal policy here, you can see, and the orange line is at 1, has a steady state that moves everybody to 1, right? So if nobody is getting treatment A, then this period about 50% or so, 52% are getting treatment A. And then if we move to, if we look at on the x-axis, where's 50%? Well, then the period after that, everybody's getting A. So it's a very quick move to a full specialization in A, as we can see here on the left-hand plot. So that's the optimal movement, right? Where time is on the x-axis, right? These periods. So regardless of where the clinician population starts, they're going to move to a full specialization in A, right? That's the goal of the guideline developer in the setting. And if we look at the laissez-faire trajectory, we can see, especially for the blue line, right, that difference that I was talking about of if clinicians are already specialized in B, right, and they start, then they're going to start to build that specialization even more, right, until they reach kind of full specialization B, which is the furthest away kind of from what you want in the long term. And once again, if we say that B is easier to learn than A, then as you can see, the shape flips vertically, right? So qualitatively, the kind of the goal of the social planner is the same. The structure is the same. The preferences and everything, are the same. It's just that because we're looking at both mu and phi, right? Both treatment effect and ease of learning. In this case, the phi overpowers the mu. So the actual treatment you recommend is not A, it's now B, right? And that since B is so much easier to learn, right, you get so much less distortion by moving everybody there. And you get more, you get better patient outcomes, right, from the same amount of constant practice as you treat all of your patients with B, right? You get a better outcome. And so in the last example, which is arguably the most interesting dynamically, this is one that somewhat fits the VBD-CD model, right? Or example. It's one where learning by doing is high, right? Practice really matters for patient outcomes. And the relative treatment effect is somewhat muddy. It's low, right? So A is a little bit better than B, but it's not a huge difference, as we see with VBD and CD, where there's been a lot of flip-flopping back and forth over the decades on trying to identify what is actually better. Likely, if in a perfect knowledge world, we'd probably be in this setting. And here there are multiple optimal steady states. This is interesting because the social planner's role here is not even to encourage, a singular best treatment, right? It's to just encourage the closest specialization. And the threshold for what is closest depends on, right, relative treatment effect, ease of learning, but also on the starting state, right? That is, how experienced are clinicians today in A, and how experienced are they in B? And this captures the full static intuition of balancing these different parameters, but it has more interesting implications in terms of changing a recommendation, right, kind of mid-flight, without patient or treatment characteristics changing at all. So here we can see this optimal policy is interesting, where this vertical line represents that threshold I was talking about. That if you're to the right of this threshold, that if your clinicians are specialized enough in A, the goal is for next period to fully move them to A. And if you're below that threshold, fully move them to B. And so if we look at that trajectories, that's what happens, right? Remember, so this threshold is about 0.4. For the kind of for the specific numbers I chose, right? And here we see that 0.8 is above 0.4, the orange line, and so optimally, they move to everybody. Everybody's subsidized to use A until everybody does, and then in the other case where there's a specialization in B, no, there's a move to B. And we can see that the clinicians by themselves seem to also follow a similar trend, just slower, right? That the high learning by doing moves them in the right direction. Kind of they correctly want to specialize, right, in whatever's closest. But a word of caution is that these starting parameters don't capture the full story in this example. Because if we choose starting parameters closer to the threshold, but both above 0.4, so for example, here 0.5 and 0.45, we see that the optimal choice is to get both of them to move to A. But we see in the laissez-faire case, these clinicians are slowly, actually diverging, right? But they're very slowly kind of moving to a specialization, which is the worst outcome, right? Which is when there's high gains to specialization, there's a high return to being really good at one procedure. It's bad to mix in the setting, right? And so these clinicians can kind of get stuck where they're not very good at A, they're not very good at B, and so they don't have any reason to move over time, right? Because they're not really gaining skill in one versus another, and they're not benefiting patients by choosing one versus another. And once again, if we move phi, right, that counteracts the kind of, you can think of the sign, right, of what the optimal treatment is. So qualitatively, things are similar, but once again, B is recommended instead of A. So let's see, there's a chat. Yeah. Okay, so I don't think I have time for extension, right? But very briefly, just as when there's heterogeneous clinicians, right, the policy needs to kind of balance both their levels of skill, and you get a more interesting case in example 3, but I don't have time to talk about that. So let's do a quick discussion. What have I told you? Tried and true can be better, right? It may be optimal to recommend a treatment with worse trial results. And what I'm saying is that there should be a higher standard for recommending new treatments. So before you recommend if a trial is better, right? But now I say there's a higher threshold, right? That you recommend if the trial results are good enough to overcome the existing human capital, right? Learning by doing effects and asymmetric kind of ease of learning, right, in the current treatment. And so this is a call to action, is that we should condition guidelines and guideline policies on measures of skill, or at least their proxies, right? Something that isn't currently common. And likely the guideline reaction to the TBT trial was suboptimal, given the high level of human capital in the use of BBD that is now lost. And the second headline, right, is that optimal policy may change over time. So suppose pre-2000, breech delivery was optimal. Then the term breech trial led to higher use of CD based on the guidelines, right? And then there's a skill loss, right, in BBD. And so maybe CD actually is optimal now, right? if in the year 2000 it would have been better to be, kind of conservative and not strongly recommend one treatment over another, or even recommend BBD, it may be optimal to actually recommend cesarean delivery now, because the skills have been lost. Because it would be too costly for current patients to get clinicians to relearn BBD, right? Even if that initial move was a mistake. So this is that knowing the up-to-date specializations, right, the up-to-date treatment used by clinicians is important, right? That you can't simply look at a meta-analysis, right, over decades to try and conclude what is the best policy today. So this complicates the problem. So let me conclude. So my research question was, how should guidelines account for clinician skill? And I tell you that they should balance, right, existing skill, ease of learning, but also the innovation, the treatment effectiveness that is usually the main thing that's looked at. And I use three main ingredients. I use a diverse patient population. I use recent learning by doing, and I use short-term focused clinicians. And these three ingredients are enough to show that a tried and true treatment can be better, that there should be a higher standard for medical innovation being adopted and encouraged, and that optimal policy may change over time, right? Is that not only should guidelines probably be more conservative, or at least focused on different things in addition, right, to what they're looking at now, but also that more up-to-date information really is important, even if the patient population isn't changing, right? As long as the clinician skill profile is changing, right? And finally, if you remember anything from this talk, I hope it's that guideline policy should pay attention to skill. Thank you. All right, any questions?
Thanks a lot, Valentyn. Yeah, if there's any questions, go ahead and unmute. So thanks for very thought-provoking talk there. You only got about a minute, so probably one question if people have one.
Yeah, Michel.
Yeah, thank you very much. That was really interesting. How important is it for your conclusions that the social planner knows exactly the response of each individual patient to each treatment, as opposed to the distribution? If the only thing that the social planner knows is the distribution, do you get the same results?
Oh, yes, yeah.
Okay.
Yeah. In fact, yeah, I think you get the exact same result too. If it's just a distributional issue, yeah.
Okay. Thank you.
Yeah. Any other questions? Okay. Oh, sorry, Jonathan or Christopher? I saw some hands raised.
Yeah, sorry. I just wondered whether or not this would have an application in the rate of adoption. So I understand about the policy change, but to me, I think about being able to predict the rate of adoption. I think this would be an excellent tool to do that. Have you thought about that?
Yeah, so I actually, I haven't thought, I've been working a lot on the different extensions and issues with this approach. Yeah, to be honest, I haven't thought a lot about on the other side of it, like voluntary adoption by clinicians. I'd be happy to talk about it more if you have some thoughts coming up on that.
Unfortunately, I got to go to another meeting.
Yeah, but thanks. No, I really haven't thought about that.
Yeah. Okay. Thanks.
And I think Jonathan had a quick hand raised.
Nope. Just
okay.
really interesting talk.
Okay. All right. Well, in that case, thanks again for inviting me. I hope you enjoyed it.
Okay. Well, thank you very much for being able to present. I hope everyone has a good rest of your afternoon.
All right. Thank you. Bye.
Thank you very much.